Okay, hi, my name is Rohit Sharma, and I'll be presenting about what is congestive heart failure. Okay, so congestive heart failure is a condition where the heart is unable to pump blood to the body the inadequate amount, leading to build up congestion in tissues and also the organs. There are many causes of this, such as it could be coronary artery disease, high blood pressure, diabetes, myocardial infarction, cardiomyopathy, or heart valve disease. Okay, now I'll be next. On the next slide, I'll be talking about what is left side heart failure. Okay, so in this condition, the left ventricle, which is responsible for pumping blood, oxygenated blood to the body, becomes inefficient. As a result, blood backs up into the lungs, which will cause pulmonary congestion. And the causes of left heart failure include ischemic heart disease, hypertension, vascular heart disease, and cardiomyopathy. Patients with left side heart failure often experience symptoms such as shortness of breath, especially during exertion or when lying down, fatigue, and persistent cough. On examination, you might find pulmonary crackles and LO-S3 gallop, tachycardia, and elevated pulmonary capillary wedge pressure. Now moving on to the right side heart failure. The right ventricle fails to pump blood efficiently to the lung, causing blood to back up into the systemic circulation. This leads to fluid accumulation in various parts of the body. Right side heart failure can be caused by left side heart failure, pulmonary hypertension, chronic lung disease like COPD, and right ventricular infarction. The symptoms of right side heart failure might include swelling in the feet, ankles, legs, or abdomen, weight gain due to fluid retention, and increased urination at night, and fatigue. On physical examination, signs such as jugular venous distension, hepatomegaly with tenderness, ascites, and pitting edema in the lower extremities can be observed. Biventricular heart failure, also known as combined, which is combined of left and right heart failure, involves dysfunction in both sides of the heart. It results in a mix of symptoms and signs from both left side and right side heart failure, indicating fluid congestions in both pulmonary and systemic circulation. This type of heart failure fails to require a comprehensive treatment approach to address the complexity of managing fluid overload and also impact cardiac function on both sides of the heart. Okay, now in our case study, we have the patient Busy Fuller, who is a 64-year-old woman with a case history of ischemic cardiomyopathy, significantly reduced ejection fraction of 25%, and she presents with symptoms of progressive dyspnea, fatigue, increased leg swelling, orthopnea, and slight nausea. On physical examination, the blood pressure was found to be elevated at 186/92, with reduced oxygen saturation between 86 to 92%. Other significant findings included jugular venous distension, crackles in the lung bases bilaterally, and pitting edema in extremities. Analyzing these symptoms and findings, we can see indication of both left side and right side heart failure. Her dyspnea, orthopnea, and pulmonary crackles point towards left side heart failure, while the peripheral edema, jugular venous distension, and slight nausea suggest right side heart failure. Based on this observation, we can diagnose the patient with biventricular heart failure involving dysfunction in both the left and the right ventricles. This highlights the importance of recognizing and treating both the aspects of heart failure to effectively manage the patient condition. That is all from me. Now I'll pass it to the next person.
Okay, now that we know that the patient has biventricular heart failure, we have to take a look if the patient has reduced ejection fraction or preserved ejection fraction. But before we dive into that, we need to know what ejection fraction actually is. Ejection fraction, or shortly known as EF, is basically just the stroke volume, which is the amount of blood ejected during systole or cardiac contraction over the end diastolic volume, which is the amount of blood which completely fills the ventricles during the diastolic phase, which is when the heart completely relaxes, and all of that times 100%. So heart failure can be divided into two main subcategories, which is HFrEF and HFpEF, which is reduced ejection fraction and preserved ejection fraction. Okay, for heart failure with reduced ejection fraction, the ejection fraction will fall below 40%, and it is known as a systolic heart failure because the problem occurs during pumping, which is during the systolic phase of the cardiac cycle. In this condition, the left ventricle will undergo eccentric LV hypertrophy, which is the left ventricle will dilate and the ventricular chamber will become big, and the cardiac contractions will become weakened. So what happens is that the cardiac muscles cannot generate enough force to propel the blood out of the left ventricles out through the aorta. So what happens is the stroke volume significantly decreases, while the end diastolic volume either maintains or increases due to the increased size of left ventricular chamber. But all of this will contribute to reduced value of ejection fraction. Next, HFpEF, which is preserved ejection fraction, will present as normal ejection fraction, which is more than 50%. However, pathological conditions still occur because this is a type of diastolic heart failure which occurs when the heart is fully relaxed. It is a problem with the filling of the left ventricles, where the left ventricular wall undergoes concentric LV hypertrophy, means that it increases in thickness. So what happens is that the left ventricular chamber shrinks. So when the heart tries to fill itself, it cannot fill adequately due to the reduced size of the left ventricles. So this will contribute to less stroke volume because there's not enough blood to be pushed out of the heart, and end diastolic volume also decreases because of the shrinking of the left ventricles. It cannot fill enough during the relaxation. However, due to the proportionate decrease in both of these parameters, the ejection fraction will appear to be normal. Now, the question is whether the patient is experiencing HFrEF or HFpEF. The answer is pretty obvious because we're given with the echocardiogram result, which is the ejection fraction is only 25%, which is less than 40%. So the patient has HFrEF. But why does this condition occur? Number one is the problem in left ventricular contractility, because we know that the patient has coronary artery disease and also diabetes, which may contribute to diabetic cardiac myopathy. Both of these conditions can contribute to the patient's ischemic cardiac myopathy condition, where the left ventricle has weakened because the cells have died due to hypoxia. Also, the patient has crisis systemic hypertension, where the afterload increases. It means the systemic blood pressure increases so high that the heart will have to strain to push blood out of the heart. So this also contributes to HFrEF.
Hi, my name is Wana Alani. So I present about the compensated or decompensated heart failure. So what is actually the compensated heart failure? It is the heart is still able to maintain the adequate blood circulation despite its weakened state. So this means that the body's needs for oxygen and nutrients are still being met sufficiently. Meanwhile, for decompensated, is the heart's pumping ability becomes inadequate to meet the body's needs. So this can lead to build up in the lungs or other parts of the body, causing symptoms like shortness of breath, fatigue, and swelling. So next is the patient experienced acute decompensated heart failure because of the symptoms that she showed. Next, which are shortness of breath, like edema, orthopnea, rapid weight gain, and also abdominal bloating. So this is because she had a heart condition that has the weak heart muscles, and also her ejection fraction is very low, which is only 25%. So what triggers it is because of the fluid overload, and because of she is not compliant with her medications. So this can be known by the clinical signs, which is the crackles in lungs, swelling in legs, and the elevated BNP levels. So next, I'll present about the mechanism and pathophysiology. So first is because of decreased cardiac output. So this patient has ischemic cardiomyopathy with a very low ejection fraction, which is 25%. So this means her heart's ability to pump blood effectively is significantly reduced. So as a result, the heart cannot meet the body's demands for oxygen and nutrients, leading to a decreased cardiac output. Second is neuronal activation. So in response to decreased cardiac output, her body activates compensatory mechanism to maintain the blood pressure and perfusions, which are the sympathetic nervous system and the RAS systems. And next is the fluid retention. So RAS system will activate increased aldosterone levels, causing the kidneys to retain sodium and water. So this leads to fluid overload and increased blood volume, which increase the preload, which is the volume of blood returning to the heart. And the fourth one is the increased preload and afterload. So increased preload stretch the heart more than normal, initially enhancing contraction strength. However, in a failing heart, this leads to an increased wall stress. Additionally, vasoconstriction from sympathetic nervous system and RAS increased afterload. So the resistance the heart must overcome to inject the blood, both of these factors further strain the heart. And the second last is the pulmonary congestion. So the left ventricle's inability to effectively pump blood, causing a backlog into the left atrium and pulmonary vein. So this will increase the pressure in the pulmonary circulation, forces fluid into the alveoli, causing pulmonary edema. So this is seen as crackle in her lung and symptoms of shortness of breath and autopnea. Last but not least is the systemic effect. So because the fluid overload leads to peripheral edema such as swelling in her legs, it will decrease the cardiac output, reduce the perfusion to vital organs, causing symptoms like fatigue, elevated BNP, and elevated BNP, which indicate the ventricular stress and fluid overload. That's all from me.
Okay, hi, I'm Priya. So I'll be explaining about the risk factors and also exacerbating factors for the patient's condition. So the first factor is advancing age. So Miss Fuller, which is our patient, is over the age of 60, she's 64, which increases her risk of getting any health conditions and also cardiovascular diseases, because as time goes, her cardiac muscles will weaken and also stiffen, causing it to be less elastic. And the next is she also has a history of ischemic cardiomyopathy. So as my team member mentioned just now, ischemic cardiomyopathy is whereby the myocardial tissue is facing difficulty in pumping blood throughout these whole tissues because of the ischemia, which is lack of oxygen, which also leads to hypoxia and also tissue cell death. So to overcome this, the myocardial tissues, especially in the left ventricle, will go through hypertrophy, which is left ventricular hypertrophy, to compensate for this lack of oxygen throughout the systemic circulation. And this worsens the condition whereby there's a greater demand for oxygen due to this hypertrophy, which would further worsen her heart condition. And next is hypertension. So hypertension is whereby the arterial pressure in the systemic circulation is higher than the myocardial pressure. So to overcome this, the left ventricular hypertrophy would need to pump more blood out due to increased workload, so that there will be more blood pumped onto the cell tissues. But this is worse because hypertension would cause even less blood to be pumped out to the systemic circulation. And the next is obesity and dyslipidemia. So Miss Fuller is obese, whereby her weight is over 84 kgs and her height is just like 5'3". So obesity causes various, it worsens the heart condition because she will have the excessive adipose tissue, which will release various cytokines such as interleukin beta and also tumor necrosis factor, which should induce inflammation. And also this will increase the levels of low density lipoproteins in her blood vessels. And also this contributes to dyslipidemia because dyslipidemia is basically like abnormal lipid levels in her blood. And next is diabetes. So when she has diabetes, this would increase the serum glucose levels and also glycated hemoglobin levels, which would cause oxidative stress to her blood vessels. And next is alcohol intake. Although she says that she only takes alcohol 3 to 4 days a week, this is still higher because alcohol, it increases the ROS, which is reactive oxygen species, which would degrade the oxidation of lipid, DNA, and also protein in blood vessels. And next is family history. So Miss Fuller, she has a family history whereby both her parents have died due to myocardial infarction in their 60s. So this further worsens her condition because she's more prone to cardiovascular disease at her age. Plus she's already old, so all these factors, including hypertension and history of ischemic cardiomyopathy, would worsen the condition even more. So now I'll pass it to the next person.
Alright, so next I'll be explaining about the possible drug interactions with her current medications that could lead to certain health problems. So we start with the drug-drug interactions that causes certain cardiovascular risk. So firstly is the interaction between aspirin and carvedilol. So that interaction between aspirin, which is an antiplatelet agent, and carvedilol, a beta blocker, can increase bleeding risk and mask hypoglycemia symptoms. So in congestive heart failure patients, the risk of bleeding could lead to drops in hemoglobin, which can worsen the heart failure symptoms. Other than that, severe hypoglycemia can also worsen the heart failure symptoms by inducing additional cardiac stress. Next is valsartan and furosemide. So valsartan, an angiotensin II receptor blocker, and furosemide, which is a loop diuretic, can lower blood pressure and have diuretic effects. Other than that, furosemide can also cause significant electrolyte disturbances. So the severe hypertension can lead to vital organs not functioning well, thus worsening heart failure symptoms. So other than that is also the drug-drug interactions that could lead to metabolic interactions. So firstly is insulin and carvedilol. So carvedilols have masking effect that makes it challenging to detect hypoglycemia. Thus, it requires frequent blood glucose monitoring to prevent severe episodes. Other than that, duloxetine and insulin. So duloxetine may increase or decrease blood sugar levels in some patients. So the fluctuations in blood glucose can add additional stress to the heart and complicate the management of congestive heart failure. Next, I'll be passing to the next person.
All right, so my name is Sarah, and I'll be continuing on with the drug interactions. So another drug interactions that she's been taking that can cause gastrointestinal interactions are aspirin and meloxicam. So this can cause a high risk of gastrointestinal bleeding and ulceration, and this could be more effects since she already has CHF. So the reason when they interact with one another, it can cause increased levels is because they're both under the same drug formation, which is NSAIDs, non-steroidal anti-inflammatory drugs. So they work by inhibiting a certain enzyme, which involves in the production of the postglands in the stomach. So another one interaction that can be is retinidine and avostatin. So this can enhance the absorption of acetylcysteine which causes the increase of lower lipid effects and can cause higher side effects from the disease that she already has. So the reason is because retinidine is a histamine 2 receptor antagonist, which reduces the stomach production acid, and this causes more avastin in the body, which causes lower cholesterol levels. So the more there is absorption of it, it leads to the increase of lipid lowering effect. So next is the melicin interaction, which also similar to avastin and retinidine is going to be duloxetine. So basically this what happens is when duloxetine is a serotonin norepinephrine reuptake inhibitor. So what it does is that it inhibits certain liver enzymes such as CYPD6 and CYP1A2. So this metabolizes the avostatin and inhibits the increase of plasma levels. So what happens to the patient is that her plasma levels will become a lot higher, and it could cause a risk of myopathy, which is when the muscles are either in pain or they're too weak to function. Another one is fluticasone and furosemide. So basically what happens is that because it's a corticosteroid, it is used to help with like asthma and like breathing problems, while furosemide is in charge of like helping with hypertension or leukemia and stuff like this, but separately. However, if they're taken together, it reduces the potassium levels. So this promotes renal extraction of potassium. So it causes the patient to have more higher risk of losing blood a lot faster than she already has, and it will make her more weak and fatigued. So next, another common interaction that can happen is the drug plus the disease, because the patient already has many occurring problems, and that she's already like having problem with her heart pumping, and this can cause the drugs that she takes could even make her condition even worse rather than helping her. So as for example, as I mentioned, the NSAID medications such as aspirin or Mexon can cause her to have more inflammation and problems and will make her condition worse. As for fluticasone and furosemide, it can exacerbate her hypoleukemia and cause even more serious concern in her condition. And as well as the duloxetine and avostacine, it can cause myopathy. Due to her already having blood issues, it will cause more problems in her muscles and it will just make her thing worse. So now I'll be moving it on to the next person.
Okay, so my name is Jet. So I'll be presenting the pharmacotherapy plan for the patients. So the pharmacotherapy plans are for the patients involve two, which are the short term and for the long term. So the patient is having, so from now we know the patient is having acute decompensated heart failure with the reduced ejection fractions. So our main aim in this pharmacotherapy is to relieve the symptom of heart failure and also treat her other diseases such as reflux, dyslipidemia, arthritis, diabetes, depression, allergies, and hypertension. So I will be presenting for the acute management for the patient. So it involves three medications, which are vasodilators, diuretics, and inotropes. So these three medications are done intravenously by a multiple IV infusion bag. So the first one, which is vasodilator, so we are giving her a nitroglycerin infusion. Nitroglycerin helps to reduce the preload and afterload of the heart. And for a dose, we help for her is the starting dose will be 5 to 10 microgram per minute, and it can be titrated up to 5 to 10 microgram every minute every 3 to 5 minutes interval. So the maximum dose is 200 micrograms. So nitroglycerin is particularly useful for patients who have pulmonary congestion and high blood pressures. So the second one is diuretics. So we are giving her furosemide. So furosemide is an diuretics to remove. It works by removing excess water from our body, thus by stimulating our kidney functions. So by getting rid of the excess water, we can reduce the volume of the blood, thus reducing the blood pressure. So the dose for furosemide will be, the starting dose will be 40 mg as for the IV bolus, and follow up by the 0.1 gram per kg per hour. So it can be increased by 0.05 to 0.1 mg every 2 hours until a desired effect is achieved. So lastly is the inotropes. So inotropes is another crucial element in the management of acute decompensated heart failure for patients with low cardiac outputs and with a signs of end organ hyperperfusion. So they help to increase cardiac contractility and improve cardiac outputs. So for this patient, we are giving her a dopamine infusion. So dopamine works by stimulating the beta-1 adrenal receptors, which helps to increase the heart contractility. So the dose for dopamine will be 2 to 5 microgram per kg per minute. So this dose is also known as inotropic dose. So which particularly useful for patients who have low cardiac outputs. Yeah, that's it for me. I will pass it to the next presenter.
Hello, my name is Koimbe Ahmad Fizal. So I'm going to continue with discharge medication. So furosemide is replaced with valsartan and HCTZ combination. So why furosemide is replaced? Because it is to increase the adherence for the patient. So valsartan 160 milligram and Divan HCT 25 milligram once daily, and it is an ARB and thiazide diuretic combination for blood pressure control and reducing fluid overload. Next. So the next is ranitidine. Ranitidine is replaced with omeprazole, which need to be taken 20 milligram once daily. So why ranitidine is replaced? Because it containing NDMA, a probable human carcinogen that can cause cancer. So omeprazole need to be taken 20 milligram once daily, and it has a better acid control and fewer side effects. Next, so the carvedilol is changed to the extended release carvedilol, which is also need to be changed for to increase the adherence. So the simplification of dosing from twice daily to once daily, and it adjusted based on current dosage. 14 as an example, 40 milligram once daily. So it is a beta blocker for heart failure and blood pressure control. So next is long-acting insulin, which insulin glutamate is replaced to long-acting insulin, such as degluted, for once daily dosing. So it is a long-acting insulin for blood sugar control and need to be taken once daily at any time. So it will improve the adherence of the patient, but the minimum of 8 hours between doses. Okay, next. So this is a newly added medication in the drug regimen. So spironolactone is added because it is beneficial in managing symptoms like weight gain and leg swelling, or in the other word, edema. So it need to be taken 20 milligram once daily, and it used to treat heart failure and reduce fluid retention. And Tylenol is added because it does not have the same risk for gastrointestinal bleeding, and generally safe for long-term use. And for your information, Tylenol is used to replace meloxicam, which has severe side effect and severe drug interaction with aspirin. Next. So this is the maintained medication: aspirin, insulin aspart, sulfenadine. So aspirin need to be taken 81 milligram once daily to reduce cardiovascular risk, and insulin aspart need to be taken 7 units subcutaneously before each meal. It is rapid acting insulin for mealtime blood sugar control. And fexofenadine need to be taken 60 milligram once daily if symptoms are well controlled. Otherwise, it need to be continued twice daily, and it is antihistamine for allergy symptom. Next. So duloxetine, nitroglycerin, atorvastatin, and fluticasone nasal spray is also maintained. So duloxetine need to be taken 30 milligram once daily for antidepressant, as antidepressant, and nitroglycerin need to be taken 0.4 milligrams sublingually if needed for chest pain, and atorvastatin need to be taken 40 milligram once daily at bedtime for lowering cholesterol and reducing cardiovascular risk. And then fluticasone nasal spray need to be taken 50 milligram once spray in each nostril once daily if symptoms are well controlled. Otherwise, it need to be continued with twice daily, and it is corticosteroid nasal spray for allergy rhinitis. So that's all from me. I pass to the next presenter.
So, hi and good morning. My name is Shafika. For my part, I will present about the non-pharmacological intervention. Next. So, I will come out with the 7 intervention for this patient, which are: the first one is positioning and leg elevation. Elevating the head of the bed is also known as the Fowler's position, which can help elevate her shortness of breath, and as this patient has difficulty in lying flat. This position helps gravity to reducing the venous return to the heart, leading to the decreasing pulmonary congestions, and can ease the respiratory distress in patients with heart failure. Additionally, elevating the leg also can help reduce the peripheral edema by promoting venous return and preventing fluid for the pooling in the lower extremities. And this can be achieved by using the pillow to pop out the leg when the patient is sitting or lying down. Next, oxygen therapy. Oxygen therapy is for use to increase the amount of oxygen in the blood, which we know that it can elevate hypoxia and improve tissue oxygenation. For this case, for the busy fuller, maintaining oxygen saturation above 92% can help reduce the strain on her heart and lungs. Moreover, fluid restriction. Restriction fluid intake manage fluid overload. A common issue in heart failure that can exacerbate symptoms like the shortness of breath and edema. For busy failure, a typical recommendation might to be limit fluid intake around 1.5 to 2 liters per day. Then, next, sodium restriction. Sodium restriction about the low sodium diet help prevent fluid retention. Sodium can cause the body to retain water, which can increase the blood volume and worsen the heart failure system. The goal for busy should be to limit daily sodium intake less than 2,000 milligram. Then daily weights. We have to monitoring the daily weight is a simple and effective way to track fluid balance. For busy, for this patient who report a weight gain of 5 pounds in 3 days, this indicates that fluid retention of her and the need for her to adjustment in therapy. According to the American Heart Association, an increase of 2 until 3 pounds in day or 5 pounds in a week can signal this patient have a fluid overload. Next, the lifestyle changes. Busy should reduce her alcohol intake because alcohol can contribute to the heart failure and interact with other medications. Limit alcohol can help improve our health. The last one is physical activities. Strenuous activity should be avoided and it should replace with the light to moderate physical activity to help improve overall cardiovascular health, enhance circulation and maintains muscle strength. It's important to know that to tailor activity level to know what this patient can handle. Consult a physical therapist, or we also can consult a physical therapist or join a cardiac rehabilitation program to create a suitable exercise plan. Okay, I will pass to the next patient.
Alright, my name is Shafika and I'll be talking about the monitoring for the patient. So the first monitoring is to monitor the patient's EF value as she has low EF value, about for 25% only. So EF measurement is a key measure of how well the heart is pumping. It indicates the percentage of the blood leaving the heart each time it contracts. So in the patient, she has ADHF. This measure helps in assessing the severity of the condition. Regularly checking the EF helps determine in the treatment plan whether it is effective or it needs any adjustment. For instance, improvements in the EF may indicate successful management of the heart failure, while declining EF may signal that they need more aggressive interventions. So for the patient with severely reduced EF who do not respond to conventional treatments, monitoring EF can help in making timely decisions regarding advanced therapies like implantable cardioverter defibrillators, cardiac resynchronization therapy, or even heart transplantation. Next is monitoring the patient's blood pressure to ensure that it is at normal range. So blood pressure provides important information about the hemodynamic status of the patient. It helps in understanding how well the heart is functioning and how efficiently it is pumping to the rest of the body. So some treatments for heart failure like intravenous vasodilators or inotropes can significantly affect the blood pressure. So regular monitoring helps in early detection of adverse effects, allowing for timely intervention to prevent serious complication. So blood pressure readings help in evaluating the patient's response to treatment. Improving the stabilization of the blood pressure can be a sign of effective management, while worsening the blood pressure can indicate a need for a change in the treatment plan. Besides that is monitoring the patient's weight and cortisol level. As the patient is significantly overweight, her weight should be maintained at a normal level to prevent other damage towards the heart. So a weight gain in the patient while with acute decompensated heart failure often indicates fluid retention. So heart failure can lead to fluid accumulation in the tissue, which is edema, and in the lungs, which is pulmonary congestion. So monitoring the weight helps detect these changes earlier, allowing for timely adjustment in diuretic therapy. So certain heart failure medication like diuretics can cause significant change in fluid balance. So monitoring the weight helps ensure this medication doses are appropriate to the management symptoms without causing dehydration or electrolyte imbalance. Patients with heart failure often have multiple comorbidities, including dyslipidemia. Managing cholesterol level is a part of a comprehensive approach to improving overall cardiovascular health and outcomes in heart failure patients. So beside that is monitoring her kidney function, as she has edema and slightly low sodium level. As she is taking multiple treatments for her disease, monitoring her drug adverse effect is needed to ensure all the drugs are working efficiently in the body. Lastly is many patients with acute decompensated heart failure also have diabetes. So poor glucose control can worsen heart failure outcomes. So monitoring her glucose level helps in management this comorbidity effect. Some heart failure medication like corticosteroid can elevate the blood glucose level. So regular monitoring helps detect these changes early, allowing for appropriate adjustment in diabetic management. Swelling or even edema is a common symptom in heart failure, so indicating fluid retention. Monitoring swelling in areas such as legs, ankles, and abdomen help in assessing the severity of the fluid overload. Monitoring swelling helps in balancing fluid intake and output, ensuring that the diuretic are dosed appropriately to relieve the symptoms without causing dehydration or electrolyte imbalance. Lastly is bloating can result from fluid accumulation in the abdominal cavity, which is known as ascites, or gastrointestinal congestion, which are common in advanced heart failure. Monitoring bloating helps assesses the extent of this congestion. So I'll pass to the next member.
Hi, I am Sani bin Abdul Rahim. So now let's move on to the clinical guidelines to treat heart failure with reduced ejection fraction of REF. So according to the clinical guidelines for the management of heart failure, 5th edition 2023, published by National Heart Association of Malaysia. So the first basis of heart failure management is pharmacological treatment. So based on the case study, the standard operating procedure SOP for the acute treatment of acute decompensated heart failure ADHF involves 3 phases, which are urgent treatment and stabilization, in hospital management, and lastly discharge and post-discharge care. So in the first phase of ADHF treatment, it is important to quickly recognize and diagnose heart failure based on clinical symptoms and signs. For Mrs. Bazifala, who presented with some symptoms such as severe shortness of breath, leg edema, orthopnea, and rapid weight gain, so the initial step is to maintain adequate oxygenation and perfusion of vital organs. This includes the administration of supplemental oxygen to alleviate hypoxemia and the use of non-invasive ventilation or mechanical ventilation in cases of severe respiratory distress. It is also necessary to continuously monitor and manage heart rate, rhythm, blood pressure, and tissue perfusion to prevent further deterioration. Furthermore, any underlying causes such as acute coronary syndrome, severe hypertension, or arrhythmia must be quickly identified and treated. Secondly, phase 2, in-hospital management. So during the in-hospital phase, the treatment plan for Mrs. Bazifala includes diuretic therapy to alleviate congestions and reduce fluid overload with intravenous loop diuretics such as furosemide that is commonly used to achieve rapid diuresis. So renal function and electrolyte levels must be closely monitored to avoid complications. Vasodilators may be administered to reduce cardiac preload and afterload, thereby improving cardiac output and relieving symptoms of congestion. Additionally, the use of inotropes may be considered for patients with low cardiac output and evidence of end organ hypoperfusion. Next slide. The final phase, which is phase 3, discharge and post-discharge care. The final phase of ADHF treatment involves comprehensive discharge planning and post-discharge care to prevent readmission and ensure optimal long-term management. Prior to discharge, the patient should receive a detailed discharge summary and a care plan, including instructions on medication, adherence, dietary modifications, fluid intake, and activity levels. Follow-up visits should schedule to monitor the patient's progress, assess hemodynamics, renal function, and adjust medications as needed. The use of biomarkers such as NT-proBNP, brain natriuretic peptide, may aid in risk stratification and guide management during follow-up. Last but not least, patient-centered approach. The patient and their family should be informed about the disease, the treatment options, and the prognosis as part of patient-centered approach. Changes in lifestyle that involve controlling weight, getting regular exercise, and giving up smoking should be promoted. So I will pass to the next person.
Alright, so in conclusion, the patient's worsening symptoms of dyspnea, weight gain, and edema likely result from fluid overload. So other contributing factors include her non-adherence to the medication regimen, as well as the interactions of drugs between her current medications. Therefore, the new pharmacotherapy plan aims to reduce the risk of bleeding, hypotension, and other adverse effects by carefully selecting and dosing medications, simplify the medication regimen to improve adherence, as well as ensure the patient takes her medications consistently, and lastly, to incorporate non-pharmacological interventions such as dietary adjustments and physical activity to support pharmacotherapy and improve overall health outcomes.